I don't know if you know already Paul Winston from Vancouver, Victoria. So finally it will be the Snuff Paul Congress, but I'm happy with this. And he will present the Vive algorithm, which is Vive, which is the acronym between Victoria and Vancouver and Verona in Italy, which is the perfect produce of the previous Snuff Congress. And François should be proud of this. Many thanks for your invitation.
Okay, well, back. Thank you so much. So I'm just going to move along for timing. So it was Alessandro Pacelli who decided to call it Vive, because it means to live, vivre en français. And this was an algorithm that we used to put together everything. But if you have an algorithm, you have this man. So we decided to make an algorithm based on the Monckeldine pathway that Thierry, that you created for the lower extremity. So this is an open access paper. It's called Novel Approach to New Onset Hemiplegic Shoulder Pain. So my hospital is an acute care hospital with rehabilitation. So we see our patients right after their stroke or in the intensive care unit. We know that hemiplegic shoulder pain is one of the most common causes of disability after stroke, and most common pain, and one of the four most common. And it's up to 70% of people will get hemiplegic shoulder pain, and it comes on fast, almost 20% in the first 10 days. If you do not treat it, you will be left with permanent loss of range of motion in the shoulder. Now, I say contracture because I don't believe that anymore. There's not a lot of evidence, but what's really important, this study out of Australia that showed within 6 months, half of your patients will have at least one contracture. And we also know that physiotherapy will not prevent contracture. I have always thought that spasticity is an emergency, just like a stroke. You need to treat it right away before you have a problem. So in my hospital, we have a spasticity urgent consult team. So this would be a patient who had due to drugs, had an anoxic injury and a stroke. And the physiotherapy would have said to me, Paul, he's getting very contracted. He started at Ashworth 1.5, he's getting worse. So we do toxin right as soon as he has problematic spasticity. So all of our patients get toxin right away. And so we are very happy. If you do not treat it, so this gentleman we treated very early, and he has a very strong associated reaction. He has a stiff knee gait, and he takes this supinated position, but his arm is actually perfect. We treated him with toxin for 2 years. He is a indigenous carver, and he can use his hand. But when he walks, he still pretends he has a stroke. So we treat them very, very early. This would be a classic patient. As soon as the physiotherapist said he is having shoulder pain and he has an Ashworth of 1+, we follow them. And when it gets to 2, we start injecting them. So this is a perfect case of injecting. This is another patient that the physiotherapist said he's getting spasticity. You can see in his wrist he is getting a lot of tone. So we decide to inject early. Now he's developing power. So as 1 week after injecting, his motor function was much better because he was not fighting his spasticity. And in Canada, we are only a socialist healthcare, so everything is free. So we can do as much toxin as we want. Now, this was the lady that I showed you before, that she had a lot of pain. So for 10 years, she had pain in her shoulder. And I showed you the cryoneurolysis before, that she did better. So this is a patient that presented 9 months after her stroke. And this is the plastic surgeon examining her. So she has spasticity. We do a nerve block, but she still has a lot of resistance in the shoulder. So this is capsulitis after stroke, which we know will go away. So she did not want a tenotomy of her pec, so Dr. Kraus did a neurectomy. I do it with cryo now. And you can see much better after neurectomy, but there is capsulitis. But she got 100% better after, when her capsulitis wore off. Now, if you do not treat these patients, you have to go to Marianne Keenan's work and do a more significant surgery. So this woman is about 20 years after her stroke, very stiff. I know, Canadian anesthesia, I know. So you can see she's very stiff in her shoulder, and her elbow, though, does reduce with the nerve block. We had done a lot of toxin. She was on 600 units of toxin, upper and lower. So in this case, Dr. Kraus did a pec tenotomy, a neurectomy, and a musculocutaneous neurectomy, and the elbow is better. So we don't want to have these patients anymore. In Canada, we did a Delphi study and found that most doctors are comfortable treating toxin if Ashworth is 2 early after stroke, but many of us will do it at 1+ if it's a problem. Now, moving to Italy, Pacelli's group just published a very nice paper looking at early intervention for toxins, and they concluded if you treat the people within 12 months, you will get 12 weeks, you will have a better outcome. Now, the Italians are very good at early intervention, they're very good at shoulder, but my specialty area is in complex regional pain syndrome, la SRDC. And I see, for all my orthopedics, I have an urgent access clinic, so I see about 4 new patients every week after fracture, and we treat them with prednisone, and we have very good results, so these are how we fix our patients. If you are familiar with the Budapest criteria, which was just changed to the Valencia criteria, we know that CRPS happens after a trauma, and if you have, or idiopathic, but you can have type 2 if there's a nerve injury. The best papers on stroke come out of Pakistan by Kalita, who showed that 4 weeks on prednisone was very helpful, but in 50% of the patients, they will relapse, so you need to do 6 weeks. And I've been using steroids for a long time. Many people are afraid of them, but they work very well, and there's very good consensus to use steroids. Nobody will do a randomized control trial when the treatment is 15 euros for 1 month, so nobody will pay for it. So this is what it looks like after stroke. And in my hospital, it's the physiotherapists and the occupational therapists that say, doctors, there is CRPS, come now. So we treat it right away. And in order to treat pain, the Italian group has published very nicely on suprascapular nerve blocks in stroke. And they've also done on radiofrequency ablation. So this is Pacelli's team showing how to do a suprascapular nerve very deep. Now you will get a motor effect on the infraspinatus, but it's not so important in this group. And this is Pacelli's group on the suprascapular. We now do it with cryo. So before we do the shoulder, you can actually see in the groove there is a circle. That is the cryo ice ball getting the it. So we decided to create the VIVA algorithm to live, which is Victoria Verona, on how to approach the acute hemiplegic shoulder. So this is our algorithm. So what we do is we begin with the shoulder. We look at the shoulder. If the shoulder is painful and reduced range of motion, so not flaccid, we look at it and then we say, is the elbow, wrist, and hand involved? If it's no, then we look for possible shoulder pathology. The most common, remember this is new onset, so the physiotherapist will say, after their stroke we could move their arm, it was fine, but 10 days later, 1 month later, it's bad. So it's probably something new. If they had glenohumeral osteoarthritis or rotator cuff, it would have been there before. So we have to worry about adhesive capsulitis or heterotopic ossification. If it is involving the elbow, wrist, and hands, we say yes. So now we say, does it meet the Budapest criteria for CRPS? If yes, we treat it as CRPS. If it doesn't meet the criteria, much more likely to be spasticity, heterotopic ossification, not so likely. So we look to see if it meets the features of spasticity. Many times we are not sure, or they overlap. So this is where we bring in diagnostic nerve blocks. Now for this audience, diagnostic nerve blocks are normal. For 90% of the world, they've never heard of them. So most countries do not do diagnostic nerve blocks. So we are showing how to do the diagnostic nerve block to tell the difference. So if we do our blocks and the range of motion improves a lot, it's spasticity. If it does not improve a lot, it is probably back to adhesive capsulitis or CRPS. So if we do the blocks and the range of motion is better, we treat for spasticity. If no, we say, what else is going on in the shoulder? And we look for joint pathology, we try to look for contracture, we do that. So you keep going back to your loop. So this is the anatomy of the lateral pectoral nerve block that I showed before. So the pec major is on the top. The lateral pectoral nerve always is in the same place, so very easy to do. The pec minor, the medial pectoral nerve to the pec minor is harder to find, and it also has an anastomosis. So the lateral pectoral nerve goes to the ansa pectoralis and innervates the pec minor. And this is the live demo of a saline injection. On the left side of the screen, we are stimulating the medial pectoral nerve to the deeper pectoralis minor, and on the right side, we're doing the lateral pectoral nerve to the pectoralis major muscle, which is the easier one to find. And in that patient, they had toxin to their pec major. That's why it looks smaller. So my colleague did not get the pec minor when they did toxin. So here's a case. This is a left hemiplegic patient. Within 5 days of stroke, the physiotherapist said his Ashworth is about grade 2. It was very shortly grade 3 after. So we decided to inject the elbow, brachialis and brachioradialis. Did very, very well. So we were happy. And you can see him before his intervention. He has a spastic catch, a little bit of lack of range of motion, but we do 1 week later, we can see his spasticity is improving. But I have to remind him, because he had a stroke, you have to extend the arm. He keeps forgetting to use it. So we put him in extension, and 1 month later, he's getting very nice movements in his arm. So he went home doing very well from his stroke. He came back 3 months later as an outpatient with tremendous pain in the shoulder, significant reduced range of motion in the shoulder, but a perfect elbow, wrist, and hand. There's no CRPS. I tried to see if it was spasticity in the pec, and I couldn't really get a spastic catch because the range of motion was limited, so I better do a nerve block. So we do a nerve block for him, and the pec muscle went very loose, but no change in range of motion. So this is a capsulitis, not spasticity. So we do a suprascapular nerve block, interarticular injection for pain. He's okay, and 9 months later, range of motion is perfect. So we use the nerve block to distinguish between spasticity and capsulitis. So he's very happy. He then developed a spastic toe claw and needed surgical release by our orthopedic surgeon. Can you hear the sound? Oh, they can hear? Oh, okay. Je peux le dire en français or in English. I can speak it. No, it's okay. I will do this. Something happened there. I didn't. I can't launch the presentation. Oh, okay. Okay. All right, so I'll show you again with sound. So he developed severe pain in his hand. The physiotherapist said, we can't touch him, he's having pain. And you can actually see the hand is very hot. It's swollen, and I can feel swelling and edema everywhere. And I can't open it, but it's not spastic. It is capsular, swollen, and thick. He is not conscious. He is asleep still. He is unconscious. But he is making a lot of pain when I move his hand. So I'm thinking that this is more complex regional pain syndrome than spasticity. When we go up the arm, we can look at his elbow. So I'm going to look at the elbow. There's some resistance to movement. There's a catch and release, so I'm pretty sure that there's spasticity, but it's just a bit warm and boggy, so I think he has CRPS and spasticity. I look at his shoulder. There's no CRPS. This is classic spasticity. You can feel the lack of range of motion in the shoulder, and I can feel his pectoralis tendon. So he has CRPS in his hand, a little bit in his elbow, but the shoulder is spasticity. So we put him on prednisone, and we come back and see him after this. So we look at this. So he has hemiplegic shoulder pain. He has elbow wrist involved, but it is spasticity. So 4 days later, we come back after being on prednisone. The shoulder is no better. In fact, maybe the shoulder is worse. And we look at the elbow as well. And now we come back 4 or 5 days later, and the hand is no longer swollen. So you can see I can move the fingers much better. They're not hot anymore, and they're moving very nicely, and there really isn't a spastic catch at all in his fingers. The elbow is much more, he doesn't have pain now, so I can be more violent. It's a spasticity in the elbow. So by treating with the steroids, we have improved the wrist fingers and the elbow a little bit. So now we go back. We think we have spasticity in the elbow and shoulder. We don't need to do a nerve block because I'm pretty sure it's spasticity. So now I will treat with toxin. And let's see if this keeps playing. Perfect. So now we are a week after the toxin injection. He's still on prednisone. The fingers look very good. He has no more pain when I move the fingers. And the wrist is very loose, so there's no spasticity. But after my toxin injection, the elbow is full. So we know that was definitely spasticity in the elbow and the shoulder as well. So we have a very successful outcome, and the therapists are very happy. So by deciding what was what, we can treat him. So this would be, unfortunately, we have an overdose crisis, so another stroke from overdose. This patient is, again, having pain in his shoulder. The physiotherapist cannot fully abduct overhead. Now, he has good range of motion, so he could have bilateral rotator cuff problems, but unlikely. And it was getting worse over time. So the physiotherapist is showing decreased range of motion. So we decide that we will do lateral pectoral nerve blocks to reduce range of motion. And sometimes I do nerve blocks 3 times just to see if physiotherapy will help. So the other physiotherapist is showing range of motion is better now after block, so we will do toxin. So we treat him with botulinum toxin. Again, he is not able to speak yet, so he is still unconscious, but range of motion is much better. So we come see him in follow-up. He's woken up, he's doing well, range of motion is perfect. Now, he also developed spasticity in his leg, which we treated with casting and toxin, and he developed a contraction in his fingers with CRPS, so we treated the CRPS in the hand. And one of the important reasons for treating CRPS in the hand, so I take heat maps of all my patients. So you can see the heat map. This is someone else. This is a fracture. But you can see we get normalization of range of motion and heat with prednisone. But when you treat with prednisone, you often see things that you don't. So when we get rid of the swelling, this person has first dorsal interosseous wasting. So he was like this. He actually had an ulnar neuropathy. So we had to... he wasn't ready for surgery, but we actually put him in a splint and we did forced range of motion, and his ulnar nerve did heal. So that's the Viva algorithm. I have a nice connection to Verona through the dance world, through Romeo and Juliet, but I'm pleased to be working with Alessandro Pacelli, who could not come today. So we just wanted to thank you for our algorithm.
Thank you, Paul, to help us to resolve this difficult question. I would like, as we are all experts, I have a question for you in the audience. In case of hemiplegic shoulder pain, a classical hemiplegic patient with shoulder pain, no function, but no real complaint about spasticity at forearm, hygiene, and comfort. So the problem is shoulder pain at mobilization when you have to dress the patient. What would be your first line treatment? You see the patient for the first time and you have to do something. We will do intra-articular corticosteroid injection. Interesting. We will do suprascapular nerve block. I mean with marcaine for a long time effect. Okay. We will do toxin injection. Okay, AbbVie will be happy. We will do nothing except physical therapy. Okay, so which one? Yes, diagnostic nerve block. Yes, intra-articular anesthesia. Yeah. Yes, it's a test. You mean a test? It will be a test. Ça va être un test. Okay, a good test. But yes. Yes. Okay, but. Another one?
Yes, just a brace because some patients have pain when they are holding the trip, and the pain is treated with a brace. So we can propose a suspension.
Yes. My conclusion would be that we have many options and many different choice according to the doctors, and that's the reason why those algorithms need to be done to work and to build comparative study to compare block and intra-articular and so on. Yes. Okay. Okay.
Ouais, ça marche.